So good night, everyone. It's 9 p.m. exactly Cairo time, and we are back to our Wednesday nights. We have finished the ovarian cancer module over 3 months, and then we have finished after endometrial cancer module over 3 months, and we are about to finish our course for this year, for this year and a half. We will start today the cervical cancer module. We are going to start the cervical cancer module. And later on, we are going to have the general part, which is the management of complications, the management of bleeding and hemorrhage in the field, and the management of urological complications, the management of GIT complications, the management of the bowel resections, blah, blah, blah. So we are a few months to finish our course for 24-25. Our cervical cancer course is going to start today. We're going to start by HPV vaccination and frequently addressed questions. I believe most of you has heard me several times speaking about HPV vaccination and know that I have going through raising awareness of HPV screening, vaccination, and pap smears and all the screening process for cervical cancer for years right now. So in this presentation, I totally changed what I have been presenting for the last years, that I changed it to the frequently addressed questions. Whenever I'm going to start to speak about HPV, I receive many questions, either from the public or even from the doctors. So I try to answer some frequently addressed question, and I'll be more than happy for anyone of our physical or virtual attendees just to interrupt me anytime through the Q&A box or to raise his hand and even to ask, and I'll be ready to answer those questions. So whenever I started my campaigns about HPV vaccination, I really received this question several times from physicians, from healthcare providers, from many doctors. What's HPV? They haven't heard before about what's human papilloma virus. So I'm quoting those slides from the WHO. Okay, this is the World Health Organization. Human papilloma virus is a group of viruses that are extremely common worldwide. They are common beyond your imagination. And there are more than 100 types of HPV. There are up to 200 types of HPV, of which at least 14 are cancer causing. They are also known as high risk types of HPV virus. Okay, this slide is busy. I know it's a busy slide full of details, but we are going through it all through the presentation today. HPV is mainly transmitted through sexual contact, and most people are infected with HPV shortly after the onset of sexual activity. Cervical cancer is caused by sexually acquired infection with certain types of HPV. Let's remember from now the two types of HPV, which are 16 and 18, not 16 and 17, ya Husseini. Okay, 16 and 18 cause 70% of cervical cancers and precancerous cervical lesions. And there is also evidence linking HPV with cancers of the anus, of the vulva, of the vagina, of the penis, and oropharynx. And cervical cancer is the fourth most common cancer among women globally. So there are 53 genera in the family Papilloma virida, among which there are 5 generations which are associated with HPV: alpha papilloma virus, beta papilloma virus, gamma papilloma virus, mu papilloma virus, and new papilloma virus. Okay. Again, this is a slide in details. We have more than 100 types of HPV, of which at least 14 are cancer causing. The main types that you should know are 16 and 18, which cause 70% of cervical cancer, and more than 90% of HPV infection in the cervix are naturally cleared. We are going through this again. However, it is responsible for 90% of anal cancer. This is not to be so threatening or causing fear for us, because anal cancer overall is a rare disease, more common among homosexuals, but it's a rare disease. It's not a very common cancer. It is the least in the colorectal to find an anal cancer. So 90% of anal cancer is still rare. Okay, so 70% of cervical cancer is much more common than anal cancer. It's responsible for around 71% of vulvar, vaginal, or penile cancers. And again, those are rare cancers. So whenever someone asks me, why do males are not vaccinated with HPV? They should be vaccinated, not to transmit infection for females. But again, because if it's causing the penile cancer is a very rare cancer. For example, Dr. Husseini is a senior resident now. How many cases of penile cancer have you seen up till now in your residency? None. In all our career, I have no. Yes, I have seen like 3 or 4 cases. Yes, I saw it 3 or 4 times. I have been practicing now surgical oncology for around 20 years exactly. Now 20 years, I have seen 3 or 4 cases of only of penile cancer. And 72% of oropharyngeal cancer, and this is a very dramatic increase. There is a dramatic increase in oropharyngeal cancer worldwide, and there is a dramatic increase in the HPV-related oropharyngeal cancer, and this is simply related due to the increase of the rates of oral sex. So again, because many people all over the world are practicing oral sex and increasing, so we still have increasing incidence of oropharyngeal cancer secondary to HPV infection. It's responsible for virtually all cervical cancer. So the vast majority of cervical cancers are caused by HPV. 90% of anogenital warts, this is a benign condition which are caused by HPV type 6 and 11. So now we have 6, 11, 16, 18. 6 and 11 are low risk, causing the anogenital warts, and 16 and 18 are causing the cervical cancer and the other cancers. Okay. So the global incidence of HPV-related cancer, is it a global problem? We have 610,000 incident cancer per year attributed to HPV globally. 80% of them occur in less developed regions of the world. We have horrible amounts of HPV in South Africa, in Sub-Saharan Africa, and in South America, for example. It's the second most common cancer in women living in less developed regions. Let's remember that the cervical cancer is the second most common because the endometrial cancer is the most common, with an estimated 570,000 new cases in 2018 and 84 of new cases worldwide. Those are very large numbers. And in 2018, approximately 311,000 women died from cervical cancer, with more than 85% of those deaths occurring in low and middle income countries. So it's a very sad story for global disparity between the developed and developing countries, because most of this are occurring in the low developed countries because they lack the screening programs, they lack the vaccination, and most cases are presented in advanced stage. And when they are presented, they lack the radiation and the surgical skills. So mostly we are losing women worldwide due to cervical cancer. So approximately 100% of cervical cancer is related to HPV. We can't say 100% really because there is non-HPV related cervical cancer. 88% of anal cancer, 74% of vaginal cancer, 30% of vulvar cancer. Okay, those are the numbers of people infected with anal cancer, genital warts. You have seen the number of 32 million. Okay, people, 32 million, more than many countries worldwide. They are infected by genital warts secondary to HPV. So really, this is a global problem that we should address. So again, it is a very common virus and cause those cancers. Okay. This is the HPV genome and structure. I'm not going to go thoroughly through this today. Okay. Why to protect against HPV virus? Let's remember that 6 and 11 cause 90% of anogenital warts, and 16 and 18 cause 70% of cervical cancer. There are other types like 16, 18, 31, 33, 35, 39, which we call high risk group of HPV, and we have the low risk group. This is my first message for you about calming down. For those patients who come to my clinic every day, are very anxious about the anogenital warts or the genital warts. Genital warts, as we see, it's a very common problem affecting more than 32 million people worldwide. But they are caused by the low-risk HPV virus, which doesn't cause cervical cancer. So being infected with genital warts doesn't mean that you are going to have cervical cancer later on, because simply this is infection by the low-risk subtypes of HPV. Yes, you should be protected against this. This cause really severe annoyment for women affected with genital warts. Sometimes they are going to be many genital warts, sometimes they are fungating, sometimes they are like large papillae and recurrent every time and then. So it's a very annoying problems affecting females, but they came to the clinic, mostly they are very anxious. I have got anogenital warts, so I'm going to have cervical cancer later on. But this is not the story, because the story is that cervical cancer is caused by 16, 18, and other high risk groups. So you have to assure your patient, yes, this may be HPV. And this is the reason why if you have a patient with anogenital warts and then you do the pap smear or the liquid cytology for them and send the liquid cytology for DNA testing and the results came back for you that the infection with high risk HPV is negative. This doesn't mean that you are not infected with HPV, but you are not infected with the high risk group because we test the high risk group, not the low risk group. Okay? So you have to assure your patient, yes. Back to Islam Hani last week, Islam Hani presentation. In cancer control worldwide, we have the primary prevention, secondary prevention, and then tertiary prevention. What's primary prevention? Primary prevention is prevention of cancer to happen, okay? Not allowing the cancer to happen at all. Secondary prevention is through screening and the treatment of precancerous lesion. I detect the cancer in the precancerous stage, ductal lobular carcinoma in situ, ductal carcinoma in situ, endometrial hyperplasia or EIN, for example, okay? And I do secondary prevention. And tertiary prevention, which is diagnosis and treatment of invasive cancers once we diagnose. For all cancers, we have tertiary prevention. Any cancer in the world, we have tertiary prevention, which is diagnosis and treatment once cancer occur. We are trying in early stage. But in less cancers, we have the secondary prevention, which is a screening. And again, back to Islam Hani presentation, we have certain criteria to do screening for the disease, which is prevalent, which has a high incidence, where the test is cheap, and the test is replicable, and the test is fast to do, okay? And you diagnose the patient in early stages, so you do this. So for every cancer, we have the tertiary prevention. For some cancers, we have the secondary prevention, which is a screening and treatment of precancerous lesion. And for few cancers, we have the primary prevention, which is vaccination or preventing of cancers. How would I prevent cancer from primary prevention? To know the cause. Our problem with dealing with cancer is that we don't know the causes of cancers, of most common cancers. We have what we call risk factors. We have risk factors for breast cancer. We have risk factors for colorectal cancer. We have risk factors for ovarian cancer, okay? But we don't have an exact cause knowing this will cause cancer. But we have some cancers that we know the cause, okay? For example, hepatitis B virus and hepatitis C virus cause HCC. So if you prevent HPV or HPV-treated the hepatitis B virus and hepatitis C virus, you would prevent hepatocellular carcinoma. Schistosoma is causing urinary bladder cancer. So once we eradicated bilharziasis in Egypt, for example, the incidence of urinary bladder cancer dropped dramatically, and the incidence of squamous cell carcinoma just almost vanished from Egypt, and all are changing to what we call urothelial carcinoma of the bladder, okay, or transitional cell urothelial carcinoma, like worldwide. So we eradicate the squamous cell carcinoma, which is secondary to metaplasia due to schistosoma, once you know the cause. You know, for example, okay, so there's a comprehensive cervical cancer control, which include primary prevention. The cervical cancer cause is HPV. Once I knew that the HPV is the cause, I prevent the HPV, I have primary prevention. So cervical cancer, why we do cause the presidential initiative and the screening and blah, 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 why do? Because simply this is a cancer that's preventable. This is a cancer that's common and is preventable, okay? And we have the secondary prevention, which is a screening, like you have last week with Dr. Al-Azab, with the colposcopy workshop and the pap smear and blah, blah, blah. Again, next week will be Dr. Ashraf speaking in details about the secondary prevention. So again, if you know how we are preparing our curriculum, we are speaking about cervical cancer. We are speaking this week about the primary prevention. Next week, we are speaking about the secondary prevention, which is the screening and detection of precancerous lesion, which is the L cell and the H cell, low-grade squamous intraepithelial lesion and high-grade squamous intraepithelial lesion, or what we call CIN1, CIN2, CIN3. Okay, okay, L cell and H cell. No, it's L cell or H cell. Okay, L cell and H cell, and then, for example, you can't be in a cancer center and some patient coming for you with CIN1, and then you tell her, oh my God, I should do a hysterectomy for you because this is a precancerous lesion and I should remove the uterus for you. And simply, this is a disease that's 90% reversible and will not cause cancer. And the treatment is not hysterectomy for her. I have just seen a 26-year-old female that has a hysterectomy and unilateral salpingioophorectomy for CIN1, which is shit and nonsense. And mostly the doctor who has done this is not a quack. هو مش نصاب, but he is illiterate. And illiterate in medicine and in surgical practice, especially in oncology, is NASP. Okay? And practicing wrong because you don't know is something that's equal to practicing wrong and you know. okay? Because you should know. You should come every Wednesday to learn and to know, okay? This is one of your duties. So again, I quote my slides from the WHO. Vaccinations that protect against HPV 16 and 18 are recommended by WHO and have been approved for that. Okay, and the clinical trials and post-marketing surveillance have shown that HPV vaccines are safe and effective in preventing infections with HPV infection. Again, this is not quoted from a pharmaceutical company. This is not quoted from some papers. This is quoted from the WHO slides. Screening and treatment of precancerous lesion in women is a cost way effective to prevent cervical cancer. Again, ان انا ما بحضرش وما اتعلمش is not an excuse, okay? Because simply you can finish your residency, you can finish your fellowship, and you didn't attend, you didn't learn, and then the patient come for you with CIN1, and you think this is a precancerous lesion, and you do hysterectomy for her, believing that you are doing the right thing for her. انت مش عايز فلوس, you're not seeking money, you're not seeking something, but you believe, but this is your mistake. You should study. Studying in medicine is an integral part of being an efficient doctor, okay? And again, always remember that cervical cancer is a curable disease. Yes, we have seen all the deaths related to cervical cancer because most patients are coming in advanced stage. But really, cervical cancer is a very curable disease. Once detected early, it's a curable, a highly curable disease when treated rightly. So again, it causes cervical cancer, vaginal cancer, penile cancer, inner cancer, oropharyngeal cancer, and vulval cancer. Those are the infectious diseases associated with malignant transformation. Epstein parvirus, for example, cause some cancers. Hepatocellular carcinoma are related to HCV and HBV, not HPV. We have the HPV and HPV. And the vulvar, penile, anal, oropharyngeal, cervical cancers are all related to the hepatitis B virus, and the gastric cancers are related to H. pylori infection in Japan. Okay? HPV vaccination could prevent more than 90% of cancer caused by HPV from ever developing. Okay? How it will do this? It provides strong protection against new HPV infection. Vaccination is prevention and doesn't cure an infection once you have it. So if you have HPV already, okay, you can have the HPV vaccination to prevent from other strains. If you have been infected with the low risk, for example, you can prevent infection from the high risk. That's why we do vaccinate people even after having genital warts, for example. They come for us, and once they finish their treatment with the dermatologist or whatever, the cryotherapy, the laser, whatever they do to manage those genital warts, okay, we do vaccinate them because we are not going to prevent it from the low risk groups. We are going to prevent it from the high risk group. Okay? Magdi Abdel Ghani. The HPV vaccine is not used to treat HPV infection or disease caused by HPV. So I can't already have been diseased by HPV, and then what usually come that the dermatologist refers the patient for us to be treated by the Gardasil or by the HPV vaccine. And sometimes really they inject the HPV vaccine inside the lesion. This is non-evidence-based practice. There is no practice for this, but I see this usually. The patient having warts, so they are being injected with the HPV vaccine, the Cervarix or the Gardasil inside the lesion, and then they refer for us as a treatment. It's not treating modality. We do vaccinate after being infected and after the infection is clear to prevent from the other strains from the HPV, not from the current infection. And as we just stated, Hagar, because most of the genital warts are caused by the low risk HPV strains that doesn't cause cancer, not like high risk, which are caused by 16 and 18. So the question that I'm always encountering, is HPV common? The World Health Organization estimates the world prevalence of HPV is around 11.7% in women. Around more than one woman every 10 women have got HPV infection, and 21%, one of every 5 men. So if we have 1, 2, 3, 4, 5, 6, 7, we have 7 males here, we will have like 4 people infected with HPV. Okay? So the question that I'm usually said, yes, it may be prevalent worldwide, but it is not prevalent in Egypt. So what I usually answer, in Egypt, we don't have strong studies that correlate to the percentage. We have 2 papers which are very famous from Egypt, one estimating it to be 10% and the other estimating it to be 14.3%. But really this 14.3 has been done over, I believe, 1,000 patients only. So it is not a larger sample size to be to give a statistical power. Okay. So it's again a hot area of research. If someone can get a fund, for example, from some place, we can do for the Presidential Initiative now, getting some fund and then doing the rate of HPV among the population or among even the cancer patient and know the prevalence. But yet the papers which are published, they are say that between 10 to 14% of Egyptian women are affected by HPV. Okay, if you disagree, you should publish your own studies, not just say that we don't have this HPV infection in Egypt. So, is cervical cancer common in Egypt? This is something usually that again I encounter every day and then. What I say is the Globocan studies. The Globocan studies usually state that cervical cancer is the 9th most common female cancer in Egypt in women aged from 15 to 44 years in Egypt. So it is one of the common cancers in Egypt, not very common, but not very rare. And what usually I usually answer, I myself, I believe Dr. Khalid and Dr. Hamdi, I see 2 to 3 cases of cervical cancer every week, at least 2 to 3 weeks. In our center, the data that we have like 112, I believe, cervical cancer patient every year, okay? And again, we can't do this as a prevalence in Egypt because we are not, we are a tertiary referral center, so most patients, advanced cases will come to us, okay? And I, being working as gynecologist, most of the cases of advanced cervical cancer will come to me even just to have an opinion. This is not a reference, but this says that it is not a disease that is here. I passed no week without seeing at least 2 to 3 cases of cervical cancer. Mostly the 2 to 3 cases are advanced. And then if I see like 12 cases per month, I can pick 1 case every other month. So 1 case per 24, for example, which is early and operable. Okay, we have just picked one last Sunday in the clinic. Okay, so we are preparing for surgery. So what I usually say, cervical cancer is present in Egypt. It is not a common disease, but it's not that rare that you believe, simply because the cases will not go for the gynecologist. They came to the surgical oncologist and to the oncology centers. So not seeing them doesn't mean that it is not present, okay, due to the misdiagnosis. And again, this is a problem that has to be solved. And that's what I say. In Egypt, we don't have any high volume center for cervical cancer, for example, and we don't have any high volume surgeon for cervical cancer, because high volume surgeon, I believe, that means that do more than 30 cases of cervical cancer per year. And I believe in Egypt, no center do 30 cases. And if some center claims that they do 30 cases per year, for example, cervical cancer, it would be over 3 or 4 doctors. So every doctor will work 10 cases per max for cervical cancer. I claim that I myself work every year 10 to 12 cases, 1 case per month or 1 case every 2 months. So we don't have high volume centers for cervical cancers surgery. We don't have high volume surgeons for cervical cancer surgery. And no center is qualified, for example, to be accredited as Center of Excellence, not in Egypt, but in many parts in the world. We have a question here. What's your personal experience with radical trachelectomy? Bijoy Kar, can I know where are you from? Bijoy Kar, radical trachelectomy. I'm going to speak about this just in the presentation of management of early cervical cancer. Dr. Khalid Gaballa, I believe, is going to speak about it. Okay, but my own experience in radical trachelectomy, I have done only 2 or 3 cases through my whole career, through the last years. And when I asked them to go all over Egypt, I don't believe that in Egypt anyone has done more than 1 or 2 radical trachelectomies, if ever have done that. So, Dr. Mohammed Zahiri, of course, Dr. Mohammed, ثواني هفتح لحضرتك المايك. اتفضل يا دكتور محمد. I can. دكتور محمد. دكتور محمد, we can't hear you. مشكلة في السماعات من هنا ولا مشكلة؟ Please unmute yourself, Dr. Mohammed. You are muted. Please unmute yourself. You are allowed to talk, but please unmute yourself and you can ask. You are muted. So tell Dr. Mohammed unmute himself and ask. We are going through the next slides. How long protection lasts after vaccination? I'm going to answer this in the next few slides. So back to how is HPV transmitted? The most common route of HPV transmission is sexual contact. And this is a case that that's present every now and then. We say that the route of transmission is through sexual contact and through multiple partners. And so in Egypt, for example, and in Arab worlds and in Islamic countries, we are conservative countries that our people doesn't have many sexual partners, don't start sexual practice so early like the Western world, and don't practice sex after 30 years old. No, after 50 and 60 and blah, blah, blah. Okay. However, usually my answer for this, however, HPV is stable, can survive on a lot of chemical treatment and still be transmitted through non-sexual routes. Like the sexual routes, we have it, the vaginal sex, the anal sex, so it is common in homosexual to have anal cancers, HPV, the oral sex, so we have many oropharyngeal cancers, and the close skin-to-skin touching without complete sexual intercourse. So this is some sort of common practice that I see, the close skin-to-skin contact. However, non-sexual, it can be transmitted through transvaginal ultrasound probes and colposcopies, through the underwear, through the childbirth transmission from mother to children, and hand-to-hand contact, which is not very strong evidence. And my answer usually for people who say we are Islamic countries, we are conservative countries, we don't have those multiple sexual partners, my answer is that we have by religion and by our laws that the man can marry four, for example. So لو يقدر يعني. So a man can marry four. This is by the Islamic religion. Okay, so you can have a wife, for example. And what I see from my social view for patients coming for me, for example, that many Egyptian husbands are living in Gulf region, for example, or outside Egypt. So they are married there. If they are married, okay, so they have a wife in Gulf and they have a wife in Egypt, and they are away from their wives for many months all over the year. So what we see is that yes, we have multiple sexual partners legally and by religion. And of course, I do really criticize. ماشي. Yes. Dr. Muhammad, without going through details, but really I can defend my point that really what we do, I claim that usually we put our head in the sand, okay? That sexual practice and multiple partners are, I don't say they are very prevalent, but they are present in all socioeconomic levels, okay? Throughout the highest socioeconomic levels and to the lowest socioeconomic, especially in the extremes of the social economic levels. In the extremes, extremely high and extremely low, you have sexual practice beyond what you can ever imagine, Hamdi. Khaled can imagine it, but you're not you. Okay? Okay. But again, claiming that we are Islamic conservative countries, this is something that we do claim, of course, that we are Islamic, we don't lie, for example, okay, ما بنضربش ورق, ما بنكذبش, ما بنعملش. This is something that we try to convince ourselves with, but this is not the truth, and everyone knows it is not the truth. Yes. Dr. Mohammed Zeri is saying that they have many cases at NCI. Of course, they have many cases of advanced and stump and recurrence. So I believe that NCI, but again, NCI and Mansoura Oncology Center, they are referral centers for this. So it is not a very rare disease. It is present. It's not the commonest, but it's present. And if you say it is not present, you can just visit the NCI. You can visit Mansoura Oncology Center. You can visit Alexandria or Ain Shams, and you will find many cases. Thank you, Dr. Mohammed. Dr. Bijoy from India, you are welcome. Thank you. So again, this is the routes of transmission. So what are the risk factors for HPV infection? Younger age at first vaginal sexual contact. This, I do agree, it is not very common in Egypt, but again, it is common among some very low socioeconomic standards. Younger age at first oral sexual contact. Higher numbers of sexual partners. Tobacco smoking is a risk factor for HPV infection. The lower level of education and lack of insurance and non-Hispanic black races in USA. So again, what are the risk factors for HPV that cause persistence and progression to cancer? Is infection with high-risk HPV type, 16 and 18, and the other types of high-risk HPV. Immunocompromised status, this is very important for our, I see many patients who are cancer patients and have been treated from breast cancer, from any other cancer, and they ask me after chemotherapy we are immunocompromised, should we go to vaccination? And yes, I tell them, yes, you can protect yourself from HPV infection. And for all the immunocompromised patients with other immunological disease, and even the doses, if they can be less for normal individual, the doses should go to the full scheduling for the immunocompromised, as we are going to say. Co-infection with other sexually transmitted disease, of course, and tobacco smoking, please stop smoking. Okay. So nearly all sexual active people are infected with HPV within months to a few years after becoming sexually active. And by age of 54, out of every 5 women will have been infected with HPV at one point of her life. And most people who have been infected with HPV, they don't know that they have HPV. Okay. And nearly all of them will be infected with HPV within months to a few years of becoming sexually active. Around half of these infections are with high-risk HPV types. Okay. So again, I see the girls coming to my clinic, and they are very anxious, and they believe that they have HPV, and even the doctors are very anxious and believe that it will cause cancer immediately. So if I have HPV cancer, for example, in October, I'm going to be infected with cancer within few weeks to few months. So what is the natural history of high risk? I'm speaking of high risk HPV infection, 16 and 18, and the other high risk 31, 33, and potential progression. Within 1 to 2 years, I'm going to have transient infection. So after being infected with HPV, after 1 to 2 years, I'm going to have, within those 2 years, not after 1 to 2 years, but within those 2 years, I'm going to have a transient infection. Okay? Transient infection that within 2 years, most cases are going to be, the HPV is going to be cleared by self-immunity without any medications, without anything. So most cases will have a transient infection within 1 to 2 years, and then it will be simply cleared. So you have to assure your patients, you have to assure the woman coming for you anxious, that 90% of your cases are going to have self-clearance by the self-immunity. That's why we say immunocompromised patients are more vulnerable to progression and persistence of the disease, okay? However, if it persists for more than 2 years, this is what we call persistent infection. It will stay for another 0 to 2 years to go to low-grade dysplasia, and then 1 to 5 years to go to high-grade dysplasia, and then 2 to 15 years after infection to have invasive cancer, okay? So again, it's years. If you have a high-risk HPV and it's persistent, you can develop cancer 2 to 15 years after infection, but mostly this would be cleared. So having HPV now doesn't mean that you are going to have cervical cancer. Having L cell or CIN1 doesn't mean that you are going to have HPV infection within 1 or 2 years and that we have to remove your uterus right now. So if she is 35, for example, you shouldn't go and hurry to go to hysterectomy for her, because simply most or 90% of CIN1 will go back to clearance, and they be going normal within 1 or 2 years of pap smears. So if you are uninfected, this is early protection. HPV vaccination prior to sexual activity protect against types of HPV. If you have HPV infection, for most people, their immune system will clear the infection with no harm caused at all. So you have to assure your patient it is a problem, yes, but mostly it will be solved alone. The cervical cancer test can detect HPV even before cell changes occur. So we do what we call the liquid biopsy or the pap smear, and you can detect HPV even without any L cell or H cell. This will be discussed the next week with Dr. Ashraf in details. And the pap test, okay, can detect the changes, low-grade abnormality, high-grade abnormality, or even cervical cancer, and this stay 10 to 15 years, as you say. And this is next week presentation about the secondary prevention or the screening. So another claim that we meet every day, and the question, HPV vaccine is new. Is it a new vaccine? And we had like some sort of not a very good experience with COVID-19 vaccination, for example. So we had the vaccination, and then we have AstraZeneca saying that no, the vaccine wasn't that good, and it caused some problems and some cardiac problems, blah, blah, blah. So is HPV vaccine new? Let us go to the timeline. It was in 1941 that the first pap smear was done in 1941. And in 1974 to 1976, Harald Zerhausen hypothesized that in 1974 to 1976, he said that there is unknown virus in genital warts that may cause cervical cancer. There is something. He was the first to say that there is some virus that's causing genital warts and cervical cancer. By the way, Harald Zerhausen did this like 50 years ago. In 1980 to 1984, that's when our generation was born. HPV 6, 11, 16, and 18, the low risk, which is 6, 18, 6, 11, and 16, 18, the high risk, were discovered in 1980. So this has been for more than 40 years right now. They are more than 40 years old. They are much older than most of you here, okay? And in 1992, papillomavirus major capsid protein L1 self-assembled as immunogenic virus-like material. We are going to say this is the next slide. And then in 1999, it was published clearly that human papillomavirus is a necessary cause of invasive cervical cancer worldwide by Harald Zerhausen. And then in 2003, it was the capture of the first ever bivalent or two HPV DNA testing, which is 16 and 18. It was the first ever bivalent vaccine. Okay, so it is 20 years old now. By 2006, it was the first licensed quadrivalent HPV vaccine. So it is again around 18 to 19 years. It is very old. And in 2008, Harald Zerhausen won Nobel Prize for etiological role of HPV. عشان كده اتعلموا الصبر. So he discovered the HPV, or he said there is some virus, in 1974, and then like 40 years later, he won Nobel Prize. Okay, due to this etiology. By the way, Harald Zerhausen just passed away last year. Okay, he passed away just a few months ago, or by the end of 23. And then in 2009, rapid decline in presentation of genital warts after the implementation of national quadrivalent human papillomavirus vaccinations that was in Sweden and UK. And then in 2014, FDA approved the first HPV DNA test for primary cervical cancer screening that we are using right now. So this has been a 30 years procedure, a 20 years journey of vaccine. So it is not a new vaccine. It is something that hasn't been done in hurry and in catastrophic situation like what happened with COVID-19. He won Nobel Prize for that. So it is not a new vaccine. How HPV vaccine work? How it do work? Simply, this is the virus. It's a non-enveloped virus that have an envelope, which is a DNA inside. We have the DNA material inside, surrounded by what we call protein-infused capsid. So this is the cover, which is protein-infused capsid. The capsid acts to surround and protect the genetic material, the DNA material inside the virus, and it helps to bind the particular cells that the virus will need to infect to go there, okay? So the structure of human papillomavirus through this DNA genetic active material with the capsid inside. So simply how they created the vaccine, they did a non-infectious HPV. They took the capsid, they took the cover without the active genetic material inside. So we have the cover of the virus without the active viral DNA inside. So whenever you introduce it to the body will misunderstand and will think this is the virus. And so it will produce the immunity. It will enhance the immunity from the body to go and to attack this foreign capsid, which it thinks is HPV virus, and it will cause long-lasting immunity against HPV. So we remove just the active material inside and we give the capsid outside. This is how the HPV vaccination is work. So is this theory true? Will it provide a long-standing immunity when I provide the capsid without the DNA, and then the body immunity will attack and then will provide a long-standing immunity? Yes, by the long-standing studies, it has a 98% efficacy against HPV 16 and 18, which are the high-risk viruses causing CIN2 or 3. And they have 100% efficacy against HPV 16-related VIN. VIN is vaginal intraepithelial neoplasm, vulvar vaginal cancers, or vulval and vaginal cancers. And HPV 6, 11, 16, 18 related AIN, anal cancers, and related genital warts, it is 75% efficacy against them. It's 89% efficacy in males, 90%. That was published to where? It was published in the New England Journal of Medicine. Q1 journal. It's one of the best journals and most solid journals worldwide, the New England Journal, and one of the most classic and original journals. So it was published in the New England Journal of Medicine in 2020. Okay. And then from Sweden, and Sweden is a nation that really do very strong studies. They do a large nationwide study who had been vaccinated through HPV vaccination programs, and the HPV vaccination was associated with a substantially reduced risk of invasive cervical cancer, and that was too published in the New England Journal of Medicine that we have now strong long life immunity. Being vaccinated earlier gives much more long life immunity. That's why we do encourage the girls at younger age to be vaccinated from HPV. So the questions that are asked again, what are the available HPV vaccines? We have the bivalent vaccine, which is against the high risk types 16 and 18. So this is a bivalent vaccine, what we call Cervarix. Or we have the quadrivalent vaccine, which is Gardasil, which is now the most prevalent and present in Egypt. It's 16, 18, 6, 11. So 6, 11 are blue because they are low risk. 16, 18 are the high risk. And now what's found most in most worldwide, in USA, in Europe, and in most places worldwide, even in the Gulf region, is the 9-valent vaccines that protect against 16, 18 high risk, 6, 11 low risk, 31, 33, 45, 52, 58, which is high risk. Okay. So we have the 9-valent vaccine, which is called the Gardasil 9 as well. Now, what I know is that in Egypt, we are producing a bivalent Chinese vaccine or Indian vaccine that's now being produced بالشلل الموحد والهيئة القوات المسلحة. ماشي. So, but what's present in Egypt now is the bivalent vaccine, okay? And the 9-valent vaccine will be present in Egypt just in few months. Next year, it will be present. Quadrivalent is present in Egypt. No. The bivalent is present, but is not so widely used. But the quadrivalent, this is the most prevalent in Egypt, but the most prevalent worldwide in the developed countries is the 9-valent vaccine. So, what is the vaccination schedule? We have vaccination schedules that the current evidence supports the recommendation of 2-dose schedules within 9 to 14 years old. So we start to vaccinate boys and girls, especially girls from 9 years old to 14 years old. There is no maximum recommended interval between doses. However, interval no greater than 12 to 15 months is suggested. Okay. So we usually recommend that to give the 3 doses within 6 months. A third dose schedule, 0, 1 to 6, should be used for all vaccination initiated after 15 years of age. As we say, being vaccinated early, give long life immunity. If you are vaccinated after that, you have to add another dose, especially if the patient is immunocompromised. However, for the last few years, the WHO has said for economic reasons and for some reasons, you can give 1 or 2 doses schedule for primary target girls from 9 to 14, 1 to 2 doses schedule for young women from 15 to 20, and 2 doses with a 6 months interval for women older than 21 years old. What they do in UK, the NHS in the UK, they said that the number of doses depend on the age and how will the immune system work. So people under 25 usually have 1 dose. People aged 25 to 45 usually have 2 doses, between 6 to 2 years apart. People with a weakened immune system, as we said, immunocompromised, have 3 doses. So simply, we give before 15 2 doses, after 15 3 doses, but you can give before 15 1 dose and after 15 2 doses. This is the schedule. You can give 1 to 2 doses before 15 and 2 to 3 doses after 15. Mostly they say up to 26 years old or up to being sexually active. Okay, the efficacy will decrease with age. So I usually have females like 50s or 60s asking me, should I be vaccinated? And they are married, for example. I said, yes, you can be for sure vaccinated, but it will not have the same efficacy like if you bring your daughters or your siblings or something like that to be vaccinated early. Because this question I have been asked just yesterday by a very good colleague, friend. Is it safe? I'm going to bring my daughter for you to vaccinate, but please, is it safe? Okay. The most common side effects of HPV vaccines are very mild and don't last long. The swelling or pain, they are mostly related to the injection fear, because they are young females. They are very fearful from injection. We have someone here who has phobia from injections. I hope he has been cured from this. عندك injection phobia? ماشي. So there is a swelling or pain. There is some headache, high temperature, dizziness, feeling sick, tiredness. Okay, and I can claim that I have vaccinated right now more than 3,000 or 2,000 doses of vaccine. Okay, with no side effects at all seen, rather than one case with dizziness for 2 minutes after from the injection fear. Okay, the most serious side effects, such as severe allergic reaction, are very rare and have never been seen. What is said, and I'm going to Tunisia tomorrow morning to present about HPV vaccination experience in Egypt. And I had, once they announced in Tunisia that I'm going to speak about HPV vaccination, I had severe attacks from some Tunisian doctors about this doctor coming from Egypt to disseminate this culture about HPV vaccination, which is not needed. It is still debatable? No. The WHO Director General Cole, he said, okay, the WHO Director said that no man should die from a deadly disease that's both preventable and curable. This is a disease that's preventable and curable. And so it is a shame for the world to have all those diseases that we have said from a preventable and curable disease. Yes, it is not the commonest, but it's preventable and curable, so we should finish it. So what's usually is asked for me and said for you that in Japan, it has been abundant to give the vaccination because one girl died from the vaccine, 1 or 2 girls died from the vaccine, and then it was abundant in Japan. And from now then, they don't vaccinate people in Japan because Japan is a civilized country and not affected by pharma, and they don't vaccinate. And really, you have to answer them. You have to be updated. This, yes, had happened, and it has been suspended for 2 to 3 years, where they studied and they found that the death of the girl wasn't related at all to the vaccine. And 3 years ago, the vaccination of HPV has been back to Japan in the scheduled program for all the Japanese girls and students. It is back, well established now in Japan. And the new news is that the International Gynecological Cancer Society meeting in Dublin in Ireland will be just 2 weeks from now. It will be after 2 weeks. And the presidential plenary session is by the president of IGCS, who is a Japanese physician, and he is going to speak about the HPV vaccination in Japan and how they implement and how they overcome this. So please don't try to defend your thesis by saying that Japan, because Japan now is strongly, and the presidential plenary session in the International Gynecological Society is going to be about HPV vaccination status in Japan and how they implement it back in Japan. Okay? I heard some stories about HPV vaccination that do sterilization of girls and to sterilize our girls, and they are being spread by pharma to sterilize the girls of the Islamic countries and the developed countries, blah, blah, blah. We don't have any evidence for this. I have nothing against this, but we don't have evidence. And I know that they vaccinate all their girls in Canada, in USA, in Europe, in all the world, in Gulf countries, okay? So it is implemented, and you have to bring some evidence for this. So you should all know that we have a 90-70-90-23 policy. This is a worldwide WHO policy, which is 23 control rates, that by 2030, 90% of girls should be fully vaccinated with HPV vaccine by the age of 15 years old. 70% of women should be screened with high precision tests at 35 and 45 of age, and 90% of women identified with cervical cancer should receive the appropriate treatment and care. That's what we call, that is 90, 70, 90%, and so we have 30% reduction in mortality from cervical cancer. So again, the claim that we all usually meet, why you have included in the presidential initiative cervical cancer. Really, it was even in the parliament. Some great oncologists gave some sort of questionnaire to the parliament, why you are implementing a cervical cancer screening test in the presidential initiative for early screening of cancers, which is the breast cancer, the colorectal cancer, the prostate cancer, lung cancers, which are the common cancers, and cervical cancers. And the answer was simply because this is a worldwide policy that Egypt should cope with world in that, because in 2030, the cervical cancer would be eliminated, and then you will not have the vaccines, you will not have the screening test, you will not have all that, and it will be a shame by 2030 to still have your numbers of cases of cervical cancer in a world policy. So that's why the cervical cancer screening program was done in Egypt, and that's why we choose the age of 35 to be the test of screening in Egypt for cervical cancer. So the WHO, the International Gynecological Cancer Society, the European Society of Gynecological Oncology, and the Federation Internationale Gynecological Obstetrique, okay, they all said, the FIGO said that FIGO members are embedded on the front lines of global health, together are committed to solve the preventable tragedy of cervical cancer by 2030. Our global reach can help to facilitate the delivery of national projects integrated with border sexual and reproductive health service, resulting in global initiative. The ESGO is doing a preventable campaign. We have the ESGO Preventive Committee. I believe Dr. Reda Shoki from the Gynae department is one of the preventive committee in the ESGO to prevent cancer, led by Murad Groting from Turkey. Okay, and so the IGCS too has its preventable committee. In Egypt now, we had a $3 million Rotary fund that was won by Egyptians in Australia to unite by Dr. Amal Sisi from the Rotary Club to disseminate for vaccination and screening by $3 million fund from the Rotary Club. We have Dr. Mohammed Al-Azab, who has been here in Mansoura last week, doing a lot about cervical cancer screening through his society, and it has been implemented in the presidential initiative that Dr. Khalid Gaballa is representing in our center for cervical cancer. And I'd finish with that words from Theodore Ghebreyesus, Director General of World WHO. Through cost-effective, evidence-based, cost-effective, it's cost-effective, evidence-based, it is not something new, intervention, including human papillomavirus vaccination of girls, screening and treatment of precancerous lesions, and improving access to diagnosis and treatment of invasive cancer, we can eliminate cervical cancer as a public health problem and make it a disease of the past. And I invite all of you to follow our Wednesday program and then to join us in the It's Go in 12th of December in 24 in Cairo. And thank you. We have a question online. موجود فين في مصر from دكتور عبد اللطيف عادل. موجود فين في مصر دكتور عبد اللطيف in Egypt. It is present in all what we call Vaxera. Vaxera اللي هو المصل واللقاح. This is the part of the company that is responsible for all vaccinations, all the vaccinations for the children, and so it is present everywhere in Vaxera branches. So you should ask for the nearest Vaxera branch and you do it. In our Faculty of Medicine, they have just announced that yes, we are giving more than 30 vaccines for free in Faculty of Medicine. I provide it in my clinic without any commercial reasons in my clinic. So it is present in many where the quadrivalent Cervarix. Dr. Sama Bardezi, if one have type of vaccine, can take it another newer type later. If you have got the bivalent, you can have at least one dose from the 9-valent. We would recommend that to have the higher. If you have already the quadrivalent, you can have the 9-valent if you have the access. Sometimes people are vaccinated in my clinic by the quadrivalent vaccine, and then they go to the Gulf region and they are vaccinated by the 9-valent vaccine. So that's my answer, Dr. Sama. Again, there is a question that's usually asked: what's the price? The price I started 2 years ago, it was 750 pounds per dose. Okay, so for two doses, it is around 1,500 within 6 months. I don't believe it is so much for people. And now it has been 950, and now it has been raised to be 1,350 per dose. Just last week, it was 1,350. So what I usually say, I will not encourage. I really hope that it would be implemented as vaccination program for our girls in the schools. But I know the economic situation, so I wouldn't push for that. But what I would push that everyone can know about it, and those who can afford can do it, and those societies and charities that can help to give it for people who can't afford can help in that. Okay, but it's a shame that many people who can afford that. It's a shame for many people who are going to pay the price for one dose, for example, for a lunch or for a dinner, and then they don't know anything about this HPV. You should teach people. They should know where to have it, and then they have the right to choose to have it or no. And again, is it present in the Arab world? Yes, it is present now in almost all the Gulf region in the vaccination schedule for school girls. It's present in Bahrain, in Saudi Arabia, in Emirates, in Qatar, and in Oman. And so they are rich countries, and we are not rich like them. No, it have been implemented in the vaccination program in Libya and in Morocco. Okay, and then I'm going to Tunisia tomorrow morning to speak about HPV. It has been just implemented for the vaccination program in Tunisia, I believe, like 3 weeks ago in the vaccination program. So it is present in many Arab and Islamic world in the program. Dr. Lamia, you have question, you can unmute and you can say what you want.
معلش بس انا هتاكد من حاجه. يعني حضرتك قلت ان احسن وقت يتاخد فيه اللي هو من 9 ل 14 سنه، والتايم انترفال يعني اي وقت بس ما تعديش سنه لسنه ونص، صح كده، ما بين الجرعتين.
Best schedule is 1 to 2 doses within 6 months for 9 to 14 years old, or 2 to 3 doses after 15. But the best is to give it before 15 years old.
تمام.
Thank you, Dr. Lami. Dr. Muhammad, you still want to, if you want to just unmute, and I'll be happy to hear your voice if you can unmute yourself. Dr. Shru Azi, thank you so much. Very informative. Thanks, Dr. Shru. Where are you from? We know that Dr. Bijoy is from India. So, any other questions from the audience? Yes, Dr. Ahmed, yes. Just.
حضرتك اتكلمت على البروفلاكسس بتاع الاتش بي في. طب لو بيشنت مش واخده البروفلاكسس بس هي انفكتد، في سيمتومز معينه بتظهر عليها، وهل في تريتمنت بقى للاتش بي في وقتها ولا؟
So the HPV is asymptomatic, okay, but mostly the symptom is the genital warts when she comes with the genital warts. And again, what I say, when you have the genital warts, you should do the treatment of genital warts, like cryo, the laser ablation, blah blah blah, whatever you do. And then would they be vaccinated? Yes, they would be vaccinated, okay, but to protect from the other, because most of the genital warts are caused by the low risk because you came later. So we say before you came that earlier before you came that the low risk 6 and 11 usually cause the genital warts, okay, which is a very worrisome problem for the females. But again, these are low risk. The high risk 16 and 18, 33, 31, 42, 40, 50, 45, 52, and 58, which are the high risk subtypes. Usually they don't cause genital
يعني
warts.
هو الفاكسين المفروض انا هديه لكل الفيميلز بعيدا بقى عن اللو ريسك او هاي ريسك كل
all females and males from 9 to 15.
طب ميلز ليه بقى يا معتز؟
Because males would be infected by penile or oropharyngeal cancer, and they are the main source of transmission of HPV to the females. But because males are so selfish, okay, this is something that's and self-centered, so they are not going to be vaccinated. It is not easy to persuade them to be vaccinated to protect their partners. But usually, if I have vaccinated, like I have given around 2,000 to 3,000 doses of vaccine, I have vaccinated around 10 males only. So all this schedules.
بقيت السؤال بس.
Yes, دكتور خالد.
هو الورس ده يعتبر سيمتوماتيك تريتمنت، هل في اكتيف تريتمنت؟ يعني حاجه تتاخد، حاجه انتي فايرال مثلا، حاجه كده، ولا جاست؟
There is not for trade, but there is some drugs that claim that they treat HPV virus with some gel, and I'm going to give you them, but not to be like an announcement for this because I don't have strong evidence on it, but you can use it. That's feed drugs. Does laser, Dr. Sama, where are you from, Dr. Sama Bardizi? Does laser transmit HPV? We have some claims that yes, we have all those things that are used in the plastic centers, okay, and all the cosmetic centers for using this. If they are not sterilized enough, we don't have strong evidence for this. We have not strong evidence against them, but there are many claims and many studies, which are small volume studies, that yes, it may be transmitted in the cosmetic centers if they are not well sterilized between they are not patients between female and another, or it's a transvaginal ultrasound if not well transmitted between patient and another, and then colposcopy if it is not well sterilized between patient and another. So thank you, Dr. Sama from Zakazik. Any other question? أي سؤال تاني دكتور حسيني؟ So thank you so much. That was all about the primary prevention of cervical cancer. Next week we are going to the secondary prevention with the screening with Dr. Ashraf Al-Irini from مستشفى الأحرار في الزقازيق. And see you next week. Thank you. Bye bye.